Good afternoon. This is Eric Goplerud. I'm the facilitator of the Big Hospital SBIRT initiative and Senior Vice President at NORC at the University of Chicago. We're very pleased today to have three really excellent presenters who are going to be talking about practical ways of integrating alcohol and drug screening, brief intervention, and treatment into the routine practice of hospitals and other healthcare systems. By working with the healthcare systems, our presenters have developed practical solutions that you will be able to see how they can be adapted and might work or could work and will work in the settings that you work in. These trainings, if you go to the next slide, these trainings are presented in a collaboration between the National Addiction Technology and Transfer Training Center, funded by the Center for Substance Abuse Treatment. The National ATTC for SBIRT is led by IRETA, the firm, a training and consultation firm in Pittsburgh, and NORC, and by the Big Hospital SBIRT initiative. The website that you see on your screen right now is the site where all of these webinars are housed. And by tomorrow, the webinar that you're currently participating on will be available. It will be both under the resource that says webinars up on that top scroll bar, and also in that orange bar down to the right-hand corner that says on-demand webinars, as the arrow is pointing. If you go to those, the PDFs of the presentation and the webinar discussion will all be logged there, as have other presentations that we have done in this series. We encourage you to go out and look at this website because there is an incredible wealth of training materials, of information and research about the effectiveness and the practical solutions to integrating SBIRT into hospital and healthcare practice, and links to programs, trainers, innovators around the country who are working in programs like yours and who have, if not the right solution, they at least can tell you a dozen ways that didn't work for them and that can save you a fair amount of pain. I'd like to introduce then our three, oh, thank you. As we go forward, if you have questions, there is a site to the right of your screen for you to type in questions. If you see there, you just type into the questions pane and hit send, and your question will come up. At the end of each of the presentations, I will share the questions that have come up during the presentation, and ask our presenters to respond to you. We hope that what we'll be doing is generating a lot of interaction. We just don't, at this point, have the capability of doing voice questioning, but if you want to ask follow-up questions, just type into that pane, and the question will come up, and I will ask that question. Each of our facilitators, each of our presenters have also put up contact information for them, and if you want to follow up with questions, you can either send an email to us or directly contact them for further information. So with that, I'd like to turn the presentation over to Les Sperling, Les Sperling is the Chief Executive Officer of the Central Kansas Foundation. He's held that position since October of 1999. The foundation provides a full continuum of substance use prevention and treatment services to residents of Salina County and 5 locations throughout Kansas. The Central Kansas Foundation is a substance use prevention and treatment organization. Les is a licensed addiction counselor and a child custody mediator. He has 28 years of experience in the substance use disorder field, and he's been developing really creative solutions to integrating substance use care into the practice of hospitals and community health centers. And I was so excited to hear and to talk with him that I felt we really had to have Les speak to us as a group. Les?
Thank you, Eric, and good afternoon, everybody. It's a real privilege to be here today. The perspective I'm going to bring you is one of a rural setting, obviously on the plains in Kansas, and what we've done is a fairly small substance use disorder facility to expand our presence in medical settings. Just to give you a little idea of who we are small. We do have a 20-bed detoxification/residential unit along with all of our outpatient facilities in 5 locations around central and north central Kansas. Our community in Salina is about 50,000 people, and we do serve statewide with our residential beds and detoxification beds. We do offer medication-assisted withdrawal, Suboxone, opiate withdrawal, and so I'll talk a little bit more about that and how that plays into our services. The real question for us about 5 years ago, the genesis of our work, was the question, what is the future of a freestanding substance use disorder treatment facility? With the advent of the Affordable Care Act and what was happening, the messages we were receiving were about integration. We did have some concern, honestly, that our business model was going to disappear, so we really sat down and thought about how can we move forward. I'm old enough, as you can see by that picture, that I remember hospital-based treatment programs, so we kind of went back to some of those things to look at that. But what we really decided was that we did possess a very critical expertise that was not readily available in acute care facilities and primary care facilities, that to some degree that fund of knowledge that used to be there was not there, and that we saw a future of bringing that expertise into those settings. And that's the approach that we took. Certainly that was related to integration, but we did believe that SBIRT was an excellent vehicle to take us that direction. As you'll see as I'm talking through this, we kind of concurrently took 2 very different paths to the same destination. In the acute care facilities, we really focused on opening the door to providing critical services to their most chronically ill patients. Also, part of this was to, again, send the message that addiction is a chronic illness. We were a little concerned about the movement to primarily criminal justice treatment, and that there's a large population identified through SBIRT in primary and acute care of patients that really need this kind of service and early intervention. But we were targeting the reduction of high-cost care. Certainly, alcoholics and addicts were overutilizing the emergency department in the communities that we serve, and our first approach to the acute care facility simply was, we will help you with these people. By virtue of having a detoxification center and being able to do medication-assisted withdrawal, we really tried to ramp up the number of patients that we could see that were actually going to the hospital and being admitted but didn't need to be. We thought it was important, too, as part of this strategy to talk to these facilities and these practices about the overall impact of substance use disorder on general health. and those discussions have certainly been furthered by using SBIRT and doing those screenings. We also were very selfish and recognized that our patients in our SUD facilities really did lack access to primary health and oral care, and part of our strategy was to target federally qualified health centers and increase our patients' access to those important services, and then obviously, ultimately, the full integration of our services into primary and acute care settings. This was really happening at a time in Kansas where we moved our Medicaid program to a fully managed care model. There are now 3 managed care organizations doing Medicaid in Kansas, and part of that transition certainly was aligned with the Affordable Care Act in terms of an emphasis on multidisciplinary teams, health homes, medical homes, person-centered medical homes, and so it was a really excellent timing, if you will, for us to start bringing our expertise into these teams. I'll talk first about our acute care. We have the acute care hospital here, which just received their level 3 trauma center, and it was very revealing and really helped us in our discussion that the alcohol and drug readmission DRG was their second highest for that acute care facility. That was really related to a lot of data to recidivism, but also demonstrated a clear problem with acute intoxication and frequent readmission. That really served as the basis to get the discussions going, and frankly, their main objective was to reduce uncompensated care with this population. We have a federal block grant to help us with some detoxification, and as I'll talk about the outcomes, there was a huge increase and a lot of pressure on that funding stream as a result of this collaboration, but it was more than made up with other funding streams that came along. I really enjoyed the second part, the second presentation. I had a chance to look at it, and they've done a wonderful job of codifying what we kind of waded through. We made a lot of mistakes in this process, and I wish I would have had their PowerPoint presentation before we started. So thanks for their effort. But where we really started was on the acute side. SBIRT to the acute care hospital had no value to begin with because, A, there was no money attached to it, and their main concern was this uncompensated care. So we really used that emphasis on ED coverage, full-time staff in the hospital, and taking care of those critically ill people and getting them out of the hospital faster as our ticket. We are now moving towards implementation of universal screening and SBIRT this year, only a couple of months away, of all patients in this hospital. So that's very exciting that we have been able to be successful with the acutely ill and now can target and implement brief intervention. We are going through the process of the higher level obstacles, and there are many. When we approach the hospital with wanting to put staff in their facility, there's obviously credentialing, a number of things that I really didn't put down here as barriers that will be in that second presentation, but having a willingness, having a change leader within that acute care hospital really moved us along, so we had the forum to be able to solve these issues. I'm very excited that we do, this is a contract that the hospital executes with us. They saw the benefit in reimbursing us to be able to do this, and I believe nationally that there's probably not a hospital in the country that does not have this issue. I'm sure you're all aware of that, and that there are, for substance use disorder providers, community-based providers, tremendous opportunities to explore that with their hospitals. We do provide 24/7 ED coverage, and we provide a warm transportation and handoff to our detoxification center for people that present to the hospital. We've had really excellent success with that and really changed the conversation about who needs to be in the hospital and who doesn't. The other thing with having full-time staff on the med-surg floors, our addiction counselors do rounds daily with the hospitalists, and staggering secondary diagnosis numbers coming out of the hospital. The primary diagnosis is fairly small, but when you start to look at that impact of substance use disorder on the secondary diagnosis and begin to make rounds with the hospitalists, we are able to develop very effective discharge plans that increase engagement in appropriate SUD services, and accomplish that certainly by trying every time to have a warm handoff as much as we can. We actually physically deliver people from the hospital to our initial appointment as much as we possibly can. We can't do it 100% of the time, but that is the expectation, is that effort will be successful. We do use volunteers and other people, peer mentors, very valuable, but I'll talk about that a little more later. That relationship has flourished and really helped us. If you look at the outcomes, we've reduced that readmission significantly. That is related obviously to our increase in admissions, but the length of stay has been reduced, which I've not been able yet to get a hard number of the cost savings and the cost benefit that we are providing for the hospital, although they are very happy in saying in public out loud that it's substantial. But just an example is on a DRG for a Medicaid or insurance detox or Medicare detox, if we can reduce that length of stay by 1 to 2 days, that's very profitable and helpful for them, and we've been able to do that. The longer length of stay is really related to comorbidity and some very ill patients with liver disease and other things that require longer stays. When we do triage and have worked with the ED docs, 83% of those patients have not been admitted and have been admitted to our facility. And I'm really proud of the 58% number of people who have made their scheduled handoff to SUD services and mental health services. One of the other impacts that the acute care hospital speaks a lot about in the community is their, by working with intoxicated people that do need detox and having our staff on board, and by moving patients quickly out of the hospital, their adverse incidents from patients and staff related and overall have been reduced by 60%, and they give the presence of SUD staff the credit for that largely. We like to work with intoxicated people. Most medical professionals understandably do not. So we're providing, again, that expertise to alleviate some of those really tense situations. As I said, our detox business has increased dramatically. That was a challenge, not only from managing our resources, but teaching our detoxification staff how to handle patients who were more ill than we had in the past. And that is probably a long conversation that I won't have today, but we did spend a great deal of time nurturing our staff, rewarding our staff for dealing with these very ill patients, and making a focus to obviously treat them with dignity and respect on every occasion, and really ramped up the motivational interviewing skills, and I'm just very proud of that staff. Another really great benefit has been the commercial insurance revenue that has come in as a result of working with this acute care facility. It's a different patient load, or a different type of patient in a sense, than we have historically had with the criminal justice, and we have also really increased our family programs and family engagement with this population as a result of that work with the acute care hospital. Before I leave the acute care, I want to talk a little bit about the other opportunities that have been brought up as a result of the work with this one hospital. We do a pretty good job of collecting data and the outcomes, and we have published that around the state and around the region. And we are currently in talks with the Via Christi Health System, which has about 1,000 beds, acute beds in Kansas, mostly located in Wichita, and then an additional 15 critical access hospitals. If you're familiar with those in a rural setting, those are 25-bed hospitals that are often aligned with a larger acute care facility, regional facility, and we are working with them to expand our services there, and those talks are going very, very well. On the other side, the primary care side, we are very fortunate to have a very visionary federally qualified health center, the Salina Family Healthcare, that has 13 family medicine residents. We also have the Kansas University School of Medicine, actual medical school, opened here with 8 students last year, going to 32 students. So we have lots of opportunities to visit with current physicians and new physicians about substance use disorder work, and it's really, really exciting. We spent about 2 years with the Federally Qualified Health Center working through the processes of how we could implement SBIRT in the universal screening. And those of you that are familiar, the funding reimbursement schemes for acute care and rural health centers and FQHCs are very different. Originally, we had an enhanced encounter rate that was offered for universal screening. After we crunched the numbers with their people, it actually was a disincentive. So we took a risk here and just basically said, we will put substance abuse disorder staff at our expense into your FQHC if you will allow us to join your medical team and become a member of your multidisciplinary team and health home, medical home. They were willing to do that, and we have been screening every patient at least annually in that facility for 2 years now, and it's gone extremely well. The other thing that we did is we asked permission to co-locate actual Level 1 and Level 2 services at the Federally Qualified Health Center. The frustration that they had with us in the past was certainly that they would see patients that they knew needed substance use disorder treatment, but they would never make it the several blocks over to our facility. So again, the warm handoff, we do that, but we are very, very busy over there at their facility. It's just extremely exciting to me to watch a patient be screened positive, intervened with our SUD staff and medical practitioner, and if needed, be put in treatment all on the same day at the same place, and very exciting work. We've also noticed, as I'm sure the other presenters will notice, that once physicians and medical practitioners begin to see their patients changing after these interventions, their interest is increased. They're coming to our staff asking, what did you do? How did you do that? This patient is better, they're drinking less, or they're not drinking at all. And of course, that's another point about staff development. In the SBIRT program, we really had to work hard to educate staff about SBIRT overall, that we're not necessarily looking for the person who has a diagnosis. We're looking for that, or the person that rolls into the hospital with a blood alcohol of 400. We're looking for the construction worker that stepped on a nail because he's hungover or drinking too much. So that was a long process of training and continues today. We need to add additional staff over at the FQHC. You can imagine with a 23% audit C positive, 2,300 patients a year, we're pretty hard-pressed to do what we want to do as far as immediate intervention. And what happens is the med techs in this setting actually administer the audit C. If it's positive, our staff are contacted, and they are seen in coordination with the primary health care visit. Currently, with only 2 people on board, we're not able to do that 100% of the time, and we are looking at putting more people in that setting to be able to do that. Really excited about the Level 3 medical home accreditation that Salina Family Healthcare just received. We are a part of that. We have become really an integral part of that health home. This is all done by contract and memorandum. We are just two separate organizations that work very closely together, and that has worked out very, very well. The personnel has been incredibly important. I want to hit and highlight our use of recovery coaches and peer mentors. They have been invaluable both in the acute care setting, well, at every level. We did 2 years ago start a recovery-oriented systems of care recovery center at our facility. We use that. It has expanded hours. There's no appointment necessary to be served. We don't, in those particular cases, initially have to do all the required paperwork and screening tools for reimbursement. It is grant funded, so it's been extremely helpful, and the medical practitioners in our area are using it a great deal. Recovery coaches have proven to be invaluable. We do use the licensed addictions counselors in Kansas and the other clinically licensed people, and a lot of case managers back and forth to help us with that. The motivational interviewing that the ATTC has provided and other resources has been incredibly beneficial, and all the things that go with that, assessing the stages of change. We do have peer mentors that will sit in the hospital with a medically detoxing patient and provide support. We have 12-step volunteers that do that also as part of that integration effort and volunteers. So obviously for the hospital to allow that and to promote that has been a big, big benefit. It's obviously very important for our staff to understand the medical setting. It's a different culture. It's a different pace. I was telling a physician the other day, I don't believe there's more gravitas in a medical setting, but it appears that there is. We have some pretty ill people over here. Not everybody that we have put in those medical settings has succeeded, and the high level of professionalism is required, the ability to work as a team in a multidisciplinary team to understand the medical hierarchy and how those decisions are made has been critical. And interestingly enough, I would go back to the peer mentors, that they have been extremely successful in working in those situations. They're just kind of the natural helpers, natural healers that medical professionals really appreciate. I'm really excited about what's happened in Kansas. My single state authority will tell you that for the last 5 years, I have never said hello. I've never said goodbye. Whenever I see them eye to eye, the first word out of my mouth has been SBIRT. We have no grants, or we have none in the state. We've applied, so we had to do this from the ground up. And beginning January 1, SBIRT on both the medical and behavioral side is in our Medicaid plan. You can see there we have a broad array of eligible providers on the panel. We are still working through some of the training requirements. We are looking at different training products. And right now, physicians and medical professionals are required to do a 4-hour training, which we are advocating for. It's not important to do hours, it's important to do content, and are having some success there. All the way up to the health coaches will have to receive 12 hours of training to include the motivational interviewing, and so we're good with that. But in Kansas, licensed addictions counselors are part of that behavioral sciences regulatory board. Also, all the other C people or clinical licensed people are eligible to provide SBIRT services. We anticipate statewide that this is really going to take off. Those are reasonable reimbursement rates. The managed care organizations are on board to pay for this. It won't be a pre-authorized service, so I think there's a strong commitment by the state to fully integrate these services into our state, and so very, very exciting. We have yet to have been paid for SBIRT, but we're looking forward to doing that and really see that as an opportunity to expand into smaller primary care, for-profit primary care settings, and to be able to bring some revenue with us when we do that. Just briefly go through these lessons learned, and I think you'll see there's some similar ones between the two presentations, which was always nice to see that, so you might be on the right track. We spent a lot of time trying to understand those situations that we were going to go into. From my work in going to begin the conversation, they are really very different conversations in general. Acute care hospital conversations initially are related to the cost benefit. And on the FQHC side and primary care side, they are really about the improvement of patient care and how can we offer a wider array of services under one roof for your patients. The reimbursement and funding challenges for those are very important to understand, and I think everybody will agree having a champion on the medical side is essential to be able to move anything forward. We have been fortunate to have several hospital CEOs, high-ranking vice presidents, vice president patient care in Via Christi's case, that have been championing this and allowing us to get people to commit to the substantial amount of time that it takes to sort through the operational aspects of implementing these services. Data has been critical. There's, I think, 31 CPT codes that hospitals use that are related to alcohol and drug admission. We look at that data, track that data, and try to move it from year to year and identify what areas need improvement based on that data. It's also been very helpful on the federally qualified health center side with, I think it's the UB report, UBH report, somebody can correct me, where they just really look at their diagnoses on an annual basis. And again, an emphasis on that secondary diagnosis in both settings has been critical. That's really the SBIRT population we're looking at. We took the responsibility for being the problem solver in both these settings. There's a great amount of administrative work, obviously, that needs to be accomplished. We understand that medical practitioners are very busy, and our approach was just simply, we'll do it. And that included helping them prepare their credentialing applications with MCOs, just a wide variety, every administrative chore we tried to assist with. It took much longer to get here than I would have preferred, but it's well worth it. It just takes a lot of time. The other thing's pretty obvious. I had to learn this as I'm blabbing on here. Talking to physicians and administrators that are busy, if I can talk to a physician and be done in 3 minutes, I've won the day and get done what I want to do. So I really work hard to not take up a lot of their time. I'm very concerned about stigma overall, and am very pleased to see medical communities start to have an interest here. And we do, our approach is a chronic illness, and that has been successful. I'm seeing changes in attitudes in the communities where we're working in the medical facilities. We are working hard on the cost-benefit data because we do want to expand our business and reach out to additional facilities. That will be invaluable. Initially, we took the risk by putting staff in there, at least in the primary care setting, at our expense, in the hopes that we would pay off in the long run, and it certainly has. With the acute care facilities, we're going in on a contractual basis right from the start, attempting to cover our costs and then a little bit extra. Obviously, with the population co-occurring with mental health, we do provide some limited mental health services. We have the clinical staff to do that. We are working diligently to ramp that up, our capacity to do that, but also we are partnering at the primary health care centers and the hospital with the community mental health center that is located here, as well as the behavioral health unit in the acute care hospital to address these needs, and they are substantial, as you know. As a result of the business with the detox, we are expanding our beds to 30 beds in the very near future. We are really going to try to become a regional detoxification center more than we are right now. Detoxification beds, I'm sure, in most communities are at a premium. So we really believe that with SBIRT on the front end and a full continuum being able to take care of very ill patients on the detox side and get people engaged in treatment, that it's going to be hopefully a successful business model as we move forward. My voice is about to run out, Eric. There's the contact information, and if we have questions, happy to answer them.
Thanks for that, Les. Let's just gather a couple of questions here and wait for Eric to rejoin us on the line.
Okay.
Hi, this is Eric. I've been talking for the last 2 minutes to a dead phone. So let me get started again. We have several questions, and as not a surprise, many of them focus on reimbursement and cost. You mentioned, Les, that you are providing 24/7 coverage for the emergency department and also having staff on the floor in the hospital. What does it cost to provide this kind of coverage, and what experience do you have with getting paid to provide that service?
Great questions. The 24/7 coverage in the hospital, during the day, the staff that is on the med-surg floor covers the ED, so that cost is shared there. And then we do an on-call. We pay a substantial amount, $300 a weekend, and then we have some people during the week to provide on-call coverage. And so that expense is about, I'd have to look again at the whole number. The full-time staff we have on board is a full-time salaried staff. The contract with the hospital is about $160,000 a year to cover labor and on-call. And that is a fraction of what they are saving.
It really sounds like you have been making a case that doing SBIRT reduces uncompensated care for the hospital and reduces hospital 30-day readmits. Those must be seen as quite some savings. Did you feel that you had to sort of demonstrate first these kind of savings, or were you able to refer to the research literature as the way of gaining entrance into the hospital?
Really both, but I think also internally they were very aware with their readmission DRGs that this was a substantial problem. So they were, and I believe most hospitals are looking for help on this. The national data was very helpful, the SBIRT data, and then just the ability to move uncompensated care out of their building and still have people receiving the service was critical.
Mm-hmm. Sandy Lockery asks, who bills for screening and brief intervention, and would payment go to the hospital or to the substance use treatment program providing the service in the hospital?
Excellent question, and it's under negotiation. That's part of our contract agreement that we're working on. Currently, our original contract with the hospital was that any revenue that we generated goes to the hospital. I have come back to the table with SBIRT implementation and said that that's not going to work. Let's see how we can share this revenue. My goal is to have the screening that is completed by substance use disorder staff, my staff, to be compensated to us, but we want to expand where nursing staff and other settings can be trained and do that as well. and they can generate the revenue for them there. That's where we're at right now.
Michael Oyster asks, how are referrals made to a counselor to do a brief intervention? What he finds is that if medical staff ask the patient, would you like to speak to a counselor about your substance use, they often say no, or that may be a polite way of what they say. Have you had success with saying something like, I've asked a counselor to come over to consult with you over your substance abuse, or some other way? How are referrals made?
There are a couple of different ways depending on the setting. At the FQHC, it is standing operating procedure when there's a positive that our screener and our brief intervener comes into the room with the patient and the physician and talks about it. They've worked out a very nice way of doing that, and their fear was that several patients would rebel against that. That has not been the case at all. In the hospital, it is really been working well to have the staff full-time making rounds with the hospitalist. They go into the room, and it's presented in that really a motivational interviewing way that we want to visit about this. People do refuse, but we're very fortunate to have physicians that are working with us, and the substance use disorder staff are, if they get a no the first time while somebody's in the hospital, that's not the only no. They'll go back and they'll check in. They may just drop off a piece of literature, but they'll try to keep the door open. We've been very pleased with the level of engagement.
So just to follow up, when the likelihood or probable substance use issue comes up through screening, the response that you hope that the clinicians, the healthcare providers will say is, Mrs. Jones here is, I'd like you to speak to Mrs. Jones about some of the issues that were raised in the screening.
Yes.
So it's just part of routine practice.
Right, and our ultimate goal would be that all of our medical practitioners would have an interest in doing the brief intervention. That's not been the case. They are very happy to allow our substance use disorder staff to assist them with that effort. They're participating, but I think it's going to be quite a while before we've recruited enough people that they'll do it themselves.
Okay. Michael asks another question, which goes to about confidentiality and releases of information. How do you manage releases of information for these brief intervention referrals? Do the medical staff get signed releases before a counselor is called? Or does the counselor have the patient sign a release? Or how is privacy and the sharing of medical records done?
We have a qualified service organization agreement with the acute care hospital, and that covers most of that. We
say a little bit more about what a QSOA is.
A QSOA just allows companies who may share a patient but don't do exactly the same kind of work the ability to communicate without an individual release signed by each person. And so we've executed that with every medical facility, acute care facility, and that works very well and gives us access, and our legal people tell us that's okay. Excuse me. On the primary care side, we do have individual releases that we execute as part of the rooming exercise, if necessary, on a positive, and certainly patients can decline, but we've not had that happen. But we kind of really do the formal CFR 42 routine in the primary care clinic.
Okay. Talk a little bit more about the characteristics of your counselors who are working in hospitals and healthcare settings. You mentioned that they have to be able to work in very fast-paced settings, I suspect they need to know more about medical comorbidities, mental health comorbidities than some of the folks who work in your substance use treatment program. Talk a little bit more about them.
Right. I think, to me, one of the most important characteristics is the ability to manage crises. A lot of times in the ED, we have highly intoxicated people, and that ability to resolve that critical crisis situation, begin some kind of conversation, or just be able to calm the person down are skills that are hard to teach, but there are, we do train to that, but the employees who have that kind of innate ability, which is where the recovery coaches are very good, to calm those situations is critical. It's also the characteristics of anybody being able to be a very valuable team member, knowing what your role is on the team. Our staff are not there to diagnose initially. They're not there to solve the problem immediately. They are there to begin a conversation and really focus on engagement, not on counseling or anything else. So I think that ability to strike up a conversation and do that in a non-judgmental way is what actually our medical friends, professionals have told us that they admire very much about our staff characteristics, is our ability to do that. And I think that's one of the benefits we have to offer overall is when an ED doc has a choice between a 400 alcohol level and a heart attack, and we can take that 400 off their hands, they're very grateful, and those characteristics are important.
Great. Well, thank you. One last question, unless I have any more that come up, and that was you were talking about working with and developing relationships with critical access hospitals who are often in rural and frontier areas. Are you using telehealth? I know a number of states are exploring the use of telehealth for substance use services or SBIRT services.
Yes, we are moving very quickly there. We're in the process of developing those protocols. We're assessing with, it's called the Sunflower Health Network, which is a network of 15 hospitals. We're looking at all of the infrastructure to do that, but telehealth will play a critical role, at least in our rural state, to be able to do those services. We're excited about seeing how that will work.
And will that be a reimbursable service?
Yes, and actually we have a reimbursable service, but there's also a premium paid under the Medicaid plan for the telemedicine activities. It's not a great deal, but it helps.
Excellent. Well, people can still type in questions that we can have. If there's time at the end, we can come back to Les. But I would like to move on now to the presentation by Marla Oros and Colleen Hosler. Marla is the president of the Mosaic Group, a management consulting firm focused on health and human service program design. She has over 28 years of professional experience in community-based healthcare, program development, and healthcare administration. I met with Marla a couple of weeks ago, and she started talking to us about the very careful, thoughtful, practical way that she and her colleague, Colleen Hosler, have taken to understand the culture and the processes of community health centers and of hospitals so that the adoption of SBIRT into those settings takes place as seamlessly as possible, and so that they are able to monitor where or if things start to go out of control or where there are problems, that they can intervene more quickly so that the process of adoption and integration of SBIRT into the routine practice of the hospital or the healthcare system gets through that critical startup phase and becomes part of routine practice. So Ms. Oros has spent more than a decade in the Baltimore area providing technical assistance to the county health department, health systems, universities, and foundations. A lot of her work has been focused on implementing integrated behavioral health care services, including the Baltimore Buprenorphine Initiative, SBIRT in primary care practices, SBIRT in Baltimore City high schools and emergency departments, and addiction treatment models for older adults. Colleen also is working with the Mosaic Group and has been involved in planning and integrating SBIRT into primary care, into the high schools and emergency departments. I think you'll be as blown away as I was by the practicality and the insight that Marla and Colleen bring to this issue. So Marla, Colleen, I look forward to hearing your presentation.
Thanks so much. This is Marla. I'm going to start and pass the baton to my partner, Colleen. And thanks very much, Eric, for that very generous and flattering introduction. And we're just so pleased to be able to share some of the lessons that we've learned over the last couple of years in implementing SBIRT. And thanks, Les, for your terrific presentation and really setting the groundwork for a lot of what Colleen and I will share with you as well in what we've learned. So I'm going to try to find this little arrow that seems to have disappeared on the screen here. Okay, so we are an urban setting, unlike Kansas, where Les is providing his services. We have been delivering services in Baltimore, a city that has long suffered from a crisis, public health crisis in substance abuse. And while we have really worked very hard over the years in trying to expand treatment, what you see is that we still have a very significant gap in terms of those folks who need treatment and those who actually receive treatment. So you can see that we have about 70,000 folks who need treatment, only about 22,000 according to our FY 2008 data. So really, really a big, big gap. About 10% of our population reported illicit drug use just in the past month. And we are still at the top of the list in terms of being one of the heroin capitals in the country. It really is the primary drug that we deal with in the city, and you can see that it accounts for about 60% of intoxication deaths in our city. So clearly we had a need for SBIRT. We started doing SBIRT in Baltimore about 2.5 years ago, and it really started as a result of the work that Eric mentioned that we had been doing in expanding services for our heroin-addicted population using medication, primarily buprenorphine, in an initiative that we call the Baltimore Bupe Initiative. And we started that initiative back in 2006 as a way, excuse me, to really expand the access to care for opiate addiction using the medical care system, knowing that we could be able to hopefully get more doctors in the community willing to prescribe buprenorphine and then get folks into medical care and then use the medical care funding stream to provide medication-assisted treatment as well as medical care. And so the initiative was started. It's been very, very successful over the last almost 7 years. And what was really successful in terms of the foundation for SBIRT was that we've been able to recruit over 200 physicians in the city that have their waiver, and about 60 to 70 in health centers across our city who now actively participate and partner with the Bupe Initiative as continuing care providers. And so for that many years, for 4 to 5 years, when we started SBIRT, we now had this paradigm shift among our medical community in our community health centers, where those doctors who previously said, no, 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 I don't want to ever treat a patient with addiction, now they're used to treating addiction, and as Les mentioned, really seeing the benefits of what happens when patients move into recovery. And so because of that, we had this group of health centers and a readiness among those health centers, we thought, to now move back in the continuum and begin looking at early intervention. We also have had, over the last several years, as the rest of the country has, this movement to try to further integrate behavioral health services with primary health care. And so we thought SBIRT as well would be a good way to begin piloting some of that. So the goals that we started out with were to start small. So we said, let's really get into a planning process with 4 health center sites in our city to be able to see, can we really try to get SBIRT up and running. And what we did was say, let's pick early adopter centers who we know are going to be very committed to this, who are going to lead this, who are going to understand this and be willing to really suffer through all of the learning lessons that we knew we'd have to endure in this first pilot period. And another major goal, which is a little bit different than Les's model, was that we didn't have an SUD partner with us. We essentially had the health center, and our goal was to really institutionalize the SBIRT process into the existing patient flow using the existing primary care center as the core model for the delivery of SBIRT services. And so what we needed to do was figure out, how do we develop a clinical protocol based on the evidence that we knew was out there, train the folks, develop all of the program documents that we needed, and pilot it in such a way that we could then really learn to go into full implementation. And so that pilot was very successful in starting with those 4 health center sites. We were able to get the 4 centers up and running, and as a result, our funder, which was the Open Society Foundation, gave us an implementation grant that allowed us to expand to many more health centers in the city and outside of the city. We then expanded into high schools and then into the hospital, which we're going to talk primarily about this afternoon. So right now we have SBIRT actively happening and institutionalized in 24 health centers in Baltimore and around the state. The 4 high schools, unfortunately, due to funding issues in the school-based health centers, we were unable to continue that this year, but we hope to re-engage, and then the 1 hospital. And what we're really proud of, which is really what laid the foundation for our hospital work, is that we were able to really integrate SBIRT as a routine part of the practice in all of those health centers. We were able to get the SBIRT documentation, screening through brief intervention, referral into the electronic health records of those health centers that had them. And that work really has become the catalyst for a more fuller, comprehensive integration of primary care and behavioral health, and a number of the health centers that are moving in that direction. So our hospital program really came as a result of that foundation of SBIRT work that I mentioned, but also it followed on the heels of a needs assessment that Colleen and I completed for Baltimore Substance Abuse Systems focused on older adults. And we did this because of the national study that SAMHSA put out 2 years ago, really revealing this emerging trend of older adults in addiction, and because of Baltimore's significant public health issue, we were very interested in understanding the scope and scale of older adult addiction in Baltimore City. And as part of that needs assessment, Colleen and I did a very in-depth data analysis that entailed looking at 3 years' worth of statewide hospital data to really understand the admission patterns of folks who were coming into those hospitals with substance use disorders. And what we learned was that of the approximately 43,000 patients admitted per year to Baltimore City hospitals in 2010, more than half of those had a substance use-related diagnosis. And so that was not surprising, but it was fairly alarming to our City Health Commissioner and to our Substance Abuse Authority President. And at the same time that we were doing this assessment, the Commissioner had just released her Healthy Baltimore 2015 plan, and in that was a goal specific to reducing hospital admissions related to substance abuse. And the state had just put forward their 30-day hospital readmission rate program with the penalties to hospitals for those 30-day readmits. So all the stars sort of came together among these things for the City Health Department along with BSAS to really say we should really focus on piloting SBIRT in one hospital. And so the goals of our program starting out were to increase the number of patients who were identified at high risk for drug or alcohol abuse, who were actively abusing drugs or alcohol on admission. So we felt that while many of the hospitals knew the patients that were coming in purely from their symptoms, there was not a systematic way in place to really identify those who were at high risk, and certainly those who may not be clinically presenting to the hospital with a substance use disorder. And so we wanted to universally screen and identify those patients. And then we wanted to refer those patients and obviously link them to drug treatment services as a part of the discharge plan, again, sort of integrating this into the practice of the hospital. And we wanted to impact the hospital readmissions for those patients that we provided interventions. And a big piece of what we went into this with was the addition of the peer recovery support, as Les talked about. And this was a really important component that we really insisted upon in the development and the initial goals of the program, because when we looked at the literature for hospital SBIRT, while for the most part it was very positive, the areas where we saw that we could improve on was in the referrals to treatment and the follow-up that often was not as strong as it could have been with these hospital-based programs that were researched in terms of helping link patients once they were discharged. And so we really felt that we needed to, right from the beginning, put in place a system using these peer recovery coaches to do that. And so we went into this with a budget to be able to support 3 full-time peer recovery coaches. And so I'm going to talk really about the way, as Eric described, we went about doing it, sort of the nuts and bolts of how we implemented our hospital SBIRT program. And so just as an overview, and then I'm going to talk a bit about each of these steps and then turn it over to Colleen to really get into the protocol and the training. The first thing, as we did with our health centers, was to select an early adopter hospital. And I'll talk a little bit about how we did that. We organized a planning team. We conducted a patient flow analysis. We then really figured out what that protocol would be to, again, really integrate within the routine practice. And again, we didn't have a LES partner to be able to bring in and supply staff. It was really just these three peer recovery coaches and the hospital team. And so our goal was to figure out how do we really institutionalize SBIRT as a routine part of the care in the hospital. We had to figure out what screening would make sense. We had to train everybody. And then we had this new addition of the peer coach that was going to be hired by the hospital. So we had to figure out how do they now become part of the hospital team? What would their role be? How do they become integrated? And then I'm going to talk some, Colleen's going to talk some, as Eric talked about how data is really an important part of our early and ongoing implementation to be able to refine our protocols. and continue to institutionalize so that we have the best program with the best results. So in terms of the hospital selection, I know it sounds really easy. Everybody sort of throws around select the early adopter hospitals. But, you know, that really is a very deliberate and important part we found in having success with SBIRT. And so we were very careful, as we were with the health system, health center project, to think very carefully about which hospitals we would go to. And the first sort of cut that we made was very much based on data. And so because we had, as I mentioned, that hospital data analysis where we were able to see the hot button hospitals that had the most SUD admissions, we were able to sort of pick the hit list of the top 3 that we wanted to focus on. And out of that hit list, we then said, okay, which did we think would be the most committed and have the best leadership that we would be able to work with here. And so we actually picked for our first choice, and we actually picked wrong because, as it turned out, when we went to the CEO, who was very supportive, and had further conversations with the medical leadership, what we found was they actually really did not see the value of SBIRT. They were not willing to invest the time. They thought they were doing it already, and we just knew right away from the conversations that this was not going to be a good first hospital for us to work with. And so we went to our second choice, Bon Secours Hospital, which is where we have been working, and it was a fabulous partnership that was started. The CEO was absolutely committed. The ED, medical director, nursing director, behavioral health director were extremely supportive, interested. They acknowledged the huge need in the community and the desire to be able to make an impact on the care and reduce hospital admissions. And as it turned out, the ED nurses were already doing the cage as part of the national ER nursing effort. But what they said was, you know, we're doing it, but we're really not doing any. We asked the questions, but we're really not doing anything about it. So this is a fabulous way for us to really do it right. And so it was really a good choice. We then formed a team, and this we found in our health centers to be a really important part of the planning process, that you have to have the right people sitting around the table to design the program right from the beginning, not just to make the right decisions, but it establishes such a foundation of buy-in and support that then carries you through the institutionalization and ultimate sustainability. And so we did that at Bon Secours. Our team included the nursing director of the ED, the medical director, the director of the behavioral health services for the health system, the overall director of nursing staff development, and the ED nursing supervisor. And the team was very committed. As Les said, we didn't waste their time. We were very efficient with our agendas, and we did have the medical director attend almost all of the planning committee meetings, which we were very pleased about. And they really did oversee that planning process that we spent about 3 months in developing the SBIRT process. A big piece of what we have found is important to truly achieve this really integrated SBIRT model and to institutionalize it as a routine part of care is to start by really understanding how the operation works. And a lot of times, I think, when we develop programs, we make a lot of assumptions about how we think the procedure works, and it really doesn't work that way. And so what we found is to be very systematic using classic NIATEX principles of walkthroughs and flowcharts, and to really document and walk through how the operation works. And so we did that in the ED, and we did it on the hospital units relative to what we were trying to do with SBIRT. We flowcharted it, and we brought that to the planning team to say, okay, does this really reflect how you guys are working? And again, it's really surprising to see folks say, oh, well, you know, I really thought it worked like this. And we were able to then really use that workflow analysis as the basis to figure out how do we insert now SBIRT in the most effective and efficient way to make this work for this particular hospital. And so there were lots of questions and decisions that we then needed to make. Who was going to do what? The roles of staff. Who was going to do the screening? Who was going to deliver the brief interventions? Who were going to make the referrals to treatment? How were we going to integrate screening and brief intervention into the existing documentation, the nursing assessments, the progress notes, physician notes, et cetera? Where was this all going to occur? How we have these 3 peer recovery coaches. Where were they going to deliver their services? Was screening going to just happen as part of what the nurses were already doing, or the doctors? Were patients going to be, you know, put into a different room? How are we going to do this? How are we going to handle patients who were discharged from the ED versus patients that were admitted to the ED in terms of the follow-up? And then, again, a big piece of this was with these new staff that the hospital was going to hire. What was their role, and how do we really make them a key member of this team? And so one of the first things that we did was really try to understand, you know, when was the busiest time? When could we make the most impact in terms of the peer recovery coaches? And so we started out by really assessing that, understanding that, and starting out with a schedule for the 3 that really allowed for maximum coverage during the high peak times for when patients were flowing through the emergency department. And while we have instituted universal screening and coverage across the entire hospital, regardless of whether patients come in through the ED or are directly admitted, this hospital, the majority of patients that get admitted come through, about 85% come through the emergency department. So our goal was to start with the screening and BIs in the ED, follow those patients up to the unit, and then move to universal screening across the hospital. We would do all the training. We would do all the training for the nurses, the peer recovery coaches, and we still, because we're still in this pilot phase, work to turn over the SBIRT management and institutionalization to the hospital over the course of the year. So the way it ultimately worked out was, in terms of roles, was we identified that it made sense for, since the nurses were already screening using the cage, for the nurses to do the screening. And so we were able to completely change the nursing form so that the nurses would screen in the ED, as well as we changed the nursing assessment on the unit. So if the patient was directly admitted or couldn't get screened, they would get screened on the unit. We then integrated the peer recovery coaches primarily to deliver the brief interventions, and Colleen's going to talk about how the criteria for when peer recovery coaches were brought in. But one of the big decisions we made, which was very different than how SBIRT works in our health centers, was that we really took the doc out of the picture here. And we struggled to do that, and we sort of kicked and screamed because we really wanted the doc involved. But what they ended up telling us, and we needed to listen to, you know, the operation and how it worked, was that, you know, the docs in the ER, the medical providers, are really focused on stabilizing that patient medically, and we can write it in the protocol all we want, but if we really want it to happen, we need to not rely exclusively on the medical providers to deliver the BIs. And so that's really how we ended up doing it, and it seems to be working well. And so, again, Colleen's going to talk more specifically about it, but the nurses are doing some BIs for some patients. The medical providers do give brief advice on the patients who respond positively to drug questions, but not extensive brief interventions. And the coaches really are, for our team, the primary vehicle for delivering BIs and referrals to treatment. So selecting the screening instruments is another area where, again, we really work in partnership with the hospital. And while we come in, really with a sense of a lot of lessons learned, and this is how it's worked in other places, what we found is that if we let the hospital sort of look at the range of options that are out there, because as we all know, there are a lot of different tools that we can use, that again, sort of their ability to kind of select this, participate in, understand why one would work better than the other, really ultimately gains the buy-in and has it feel as if really the hospital team itself developed as they did this program. And so we did that with this hospital team, and we shared what we had learned, but we really took in mind the time for screening and how much time did we really have if the nurses were going to do this. So how many questions are really reasonable and what tools then fit with that time? How easy is it going to be, if it's complicated scoring for nurses to be doing this as part of everything else they're doing? How appropriate, culturally relevant, and other sort of, issues of reliability and validity to our target population are the various instruments we were looking at. And again, the score or no score was a factor in terms of, how it would fit with that workflow analysis that we did. And so this is where we landed. This is now a routine part of what all the nurses do. So we replace that cage with the audit C, so they do have to do a score. And then we have the one drug question: have you ever used illegal drugs or prescription drugs for non-medical reasons, and then which ones and last use. And then we actually have a readiness to change question using rulers that we have for all of the staff, and Colleen will talk about how that's an important part of the decision for how brief interventions are delivered by the coaches. So I am now going to turn it over to Colleen, who's going to talk more specifically about how this works and the training and our results.
Good afternoon, everyone. My name is Colleen. Can you hear me? And thank you, Marla. You did a great job leading up to it. Thank you, Eric and Les. So as Marla said, we spent a lot of time planning and laying out the protocols and procedures of how this SBIRT was going to work in this hospital. And as we all know, once you get down on the ground and running, the best laid plans don't always come into fruition, and we met that right away. So we had started out saying the screening was going to be completed by nurses in the ED. And what initially happened is it took a couple of months for the hospital to change the paperwork, because it's not a computerized EMR, to add that screening tool that you just saw into the nursing assessment. So we did start out with the coaches doing the screening initially, which turned out in the long run to be a really good thing because they had never done that, and it gave them a better understanding of what was going on with that screening, what were the patient's responses, how to react to them, those kind of things. So then when the nurses took over, the coaches were still really well prepared for what they were walking into by looking at the screenings. We said the delivery of the brief intervention would be done based on the scoring either by the nurse or the peer coach. And if you're familiar with the audit C, a score between 4 and 7 indicates a moderate risk of abuse on the alcohol score. And so for those that moderate risk, we said the nurses would go ahead and do the intervention with the target of trying to get the patient to reduce their use and or accept some additional treatment. But mainly with that 4 to 7, we were focused on reducing their use. For scores of 8 or higher and an answer of yes to the drug question for any drug other than marijuana, we were going to have the peer recovery coach come in and administer the brief intervention. Again, these people were probably at higher risk for dependence and addiction, and more likely that they were going to be needing a referral treatment if they were willing to accept it. However, with both parts of those brief interventions, we use the readiness ruler. If you're familiar with the readiness ruler, it's just simply a ruler that has a scale from 0 to 10, and after the screening, you ask the patient, how ready on the scale 0 to 10 are you to make some changes in your behavior? Again, that idea of trying to measure their stage of change, where they are in their journey, and whether or not they'd be willing to accept help. And for patients, and this is a typo I just see on here, that said they were at a 4 or higher on the readiness ruler, those patients would be turned to the peer recovery coach. If the nurse was doing the screening and the patient was below a 4, we thought they probably weren't ready for any real intervention, and we allowed the nurse, we kept the brief intervention with the nurse. Again, with the hopes of using motivational interviewing skills that we had done in the training to increase their readiness to change and get them higher and up on that readiness ruler. So as we finished the training and the coaches were doing the brief interventions, they would assess the patient's need for treatment and or the readiness for a referral to treatment. We did not want to send patients to treatment that weren't ready. That was a big issue in this hospital. This is a hospital where the nurses were telling us about 75% of their patients were coming in with substance use disorders. And we didn't want to just mindlessly hand them a referral to treatment and have them not show up in the revolving door. We really wanted to implement some change in the culture here. So the referral for treatment was done by the peer recovery coaches for ED discharges and for admits once we expanded throughout the hospital. We initially started in the emergency department, and then in November we expanded to work throughout the hospital. As we moved to the various units of the hospital, we were careful to meet with and discuss with the social workers and the discharge planners on each unit as to how it would best work for them for us to help with that referral to treatment. And what it turned out was they were all willing to say, we don't really know a whole lot about substance abuse treatment. Go ahead and handle it. Just let me know where they're going. And we saw throughout the hospital, though, when they were doing referrals, they were actually sending people out of state for treatment, which was not having a lot of success with our Baltimore folks. We also, more than just training the coaches to do the brief intervention and the referral to treatment, we had to provide some coaching and case management after discharge. We wanted to ensure that once our patients were linked with us, they remained with us, and we saw them all the way through this process. So the follow-up protocol that we put in place, and it's changed a couple of times, this is currently what it is that we had to design a consent form that was signed by all patients that we were referring out for treatment that allowed us to contact the Substance Abuse Treatment Center and find out a couple of things. One, if the patient actually showed up for their intake appointment, and two, if they were in treatment and compliant with treatment. So each patient that we refer for treatment signs this form, and we send the form by way of fax to the substance treatment program. We follow up with all patients. If they're in the hospital, we go and see them a second time. If they're discharged directly from the ED, we do a follow-up phone call the following day, and that's whether or not they've accepted treatment. We do make them aware of that in the conversation that the coaches have with the patient. And one challenge that we've met with in this community particularly is that cell phones get turned on and turned off, and a lot of our patients have government-issued cell phones, and the numbers change, and it's very hard to find them once they leave the hospital. Our best connection with them is why they're physically in front of us, and to give them our phone number and business cards because they will call back. For those that were admitted, we didn't just do one follow-up visit. We made it a point to at least drop in and say hello and have a small talk with them each day of their stay and build a little bit of a relationship and remind them that we were here. And, you know, sometimes when folks come in through an emergency department, the focus is not on their substance use disorder, but on their medical crisis with whatever's going on at the moment. So we found it was better on the second day or even the third day to get them to focus on the treatment process. We, for those patients that we did refer, we made a phone call within 24 hours of their appointment to remind them of their appointment, and we're very careful about any messages that might have been left, tried to get the patient directly on the phone. We followed up on the day of the appointment with the treatment center to see if the patient did arrive, in fact, for their appointment and completed their intake. If they missed that appointment, which does happen often, we then followed it up with the patient again to see if we could reschedule that appointment for them, or what barriers, what happened. Can we help you get that rescheduled to get you into treatment? And it takes a lot of phone calls, a lot of effort to keep trying to get back to these patients. It's not an easy or a quick fix, but one that the peer recovery coaches are very familiar with and do an excellent job staying with it. So the documentation we needed, and we didn't know all of this going in. We met challenges as we faced them. We had to come up with that screening form after we figured out which tool we would use, which questions we would ask, and then get that into the nursing assessment. We came up with a patient progress note, which it goes into the room with each coach as they're doing their brief intervention, and it guides them through. It reminds them to ask the patient about different obstacles or challenges in their life and about their substance use history. It reminds them to ask about their stage of change, to write down where they think they are in the stages of change, any information, family contact, who was present, former treatment options the patient has had, where they were, how long ago they were, how long have they been using, what was the date of their first use. All of those kind of things are in the progress note, and it just helps to complete the story for the coaches, which later comes in play when we're trying to find appropriate treatment. We came up with a referral form, which we give to the patient to carry with them to remind them of where they're supposed to be and on what date. And, of course, the consent to release of information, which I just explained to you. We also came up with this referral to treatment log. It became really quickly overwhelming to try to keep up with who was being referred where on what day, so we just have a log that the coaches share, and each day they look at the appointments that are listed for that day so that they can call the treatment centers and keep track of who was there. Once that's done, the patient goes into the follow-up log so we can call the patient and follow up and either say, good job, you did it, give some positive feedback, or what happened and how can we help. So each patient is put into that follow-up log, and it's really a good tracking device for us to see if we're doing a good job getting the patients from the hospital into the treatment programs, because as Marla said, we didn't have that substance abuse treatment center right there to help us. And the screening results, this is definitely data-driven, and we had to keep track of it, so we had to figure out what that was going to entail. Was the final score going to be the deciding factor of whether or not the coaches would be involved, or would it be the responses of the patient? Were we going to have the patient completed or the staff completed? And ultimately, because of it being started in the emergency department, we decided it was better for the staff to complete it because the patients were not always in a good place to do that. As we had done in our health centers, we had the paperwork scanned into the EMR. We don't have that option at the hospital, but in our health centers it works so well. If we did have that option, I would highly recommend it, because then you have a tracking system, and right now sometimes it's difficult to keep track of where the patient chart is, or to have the paperwork complete before the chart's moved on to the next place in the hospital. And then we had to have a method for provider to see the results during the encounter. We wanted the docs to know that we were there, we had talked with the patient, where the patient stood with us, and what we were going to do about it. And the feedback we've gotten from the providers has been nothing short of amazing. They're encouraged. They will call the coaches themselves for some second round of assistance if they feel it's necessary, or if a patient maybe slipped through the cracks and is now telling the provider something different, they'll call the coaches. I just repeatedly have seen increased buy-in from the providers. They're thrilled that the program is there. And I think, as Les said, they're happy to let us take care of that patient while they treat the medical. Let me see, where's my arrow? So in order to get all of this underway, we had to do a lot of training, and that training started with the Mosaic group conducting 2 full days of hourly training for all of the hospital nurses. So we kind of planted ourselves in one big conference room and rotated the nurses in and out every hour and 15 minutes for 2 days. And that training included an introduction to substance abuse as a chronic disease model, and we wanted to change the culture of thinking that these were just drug users to understanding it as a chronic illness. An overview of SBIRT, a lot of the nurses had never heard of SBIRT. An introduction to stages of change and how they could assess a patient to see where they were in that change model. A description, we were in the beginning planning stages of the peer recovery coach program and what those protocols were going to exactly look like, and actually got some input from the nurses on how they would like to see it. And then we took a lot of questions, and the nurses did present with some really good questions and gave positive feedback. They were so relieved to have somebody coming in to help with this problem, because they knew their regulars. They knew they had the same patients coming back, not every 30 days, but every week almost in some cases. So that training was around the clock for 2 days, and it was, again, very positive feedback from the nurses. So we moved on, and we hired the 3 peer recovery coaches. They were individually trained. Each training was about 64 hours total. 4 of that was hospital orientation, and 60 of it was SBIRT training. I think it could just as easily be done training all 3 of the coaches, the team to start. It was just we had different start dates, and the hospital said, let's go, let's go. So we did it 3 separate times. And that training was pretty intense. It involved an introduction to peer recovery coach roles and functions, keeping in mind that these were people who had long-term sustained recovery, but were paraprofessionals and in most cases hadn't held a job in a very long time. So we had to really set the stage of how this was going to operate for them. It was very different than training professionals in health centers that we had been doing for the previous year and a half. We talked about the disease model of substance abuse. They knew substance abuse from one side, and we had to teach it to them from the other. We had to introduce SBIRT. They had no idea, no understanding of stages of change. Motivational interviewing techniques were, that was a lot of training. There was a lot of hours involved in that. An overview of ethics and boundaries of working with patients in the hospital. Again, these were paraprofessionals who had never worked in a hospital and weren't clear on privacy and protocols and how to meet with patients. These were all people who had come from the community, how to meet with patients they may have known from the street. It was a challenge, but we got through it with a lot of role-playing and reviewing. Overview of substance abuse treatment modalities. One of the cautions I learned from this was that these coaches tend to be very sold on whatever model of treatment they came through that was their success, and maybe not as open to the other modalities. So we really had to stop and say, this isn't about you, this is about patients, and review what modality would be appropriate for what patient. Again, a lot of role-playing and teaching. The documentation requirements, we had to instill in them how important it was for documentation to be done in a hospital with the explanation, if you don't document it, it didn't happen. And we went through it, and we went through it, and we went through it, and we got it. And then we spent a lot of time doing introduction to the local substance abuse treatment providers and other key support services. And when I say introductions, we actually went out and visited them, and we saw how their programs ran. We saw what they had to offer our clients. We told them about our program. We had lunch. We went back and saw them a second and a third time, and that relationship building time was invaluable. It's cut the time that it takes us to get patients into treatment, and it also helps when we are in a tight situation with them squeezing one more patient in or helping us to get somebody transported or one more person into a shelter or a transition house or whatever it may be. That was a really important part, and again, something the peer recovery coaches needed a lot of training with. So overall, we've been doing, the grant is set up for us to do a year-long training, and we're getting close to our year. And during that time, after that initial training, that's just not enough. You have to keep a lot of oversight on these coaches, and we do that through daily emails. So at the end of each shift, they provide an email with a list of the patients they've seen, who's been referred, how they handled it, and any questions, and we're able to review that and then send an email or response back with offer any changes or possible shift in treatment plans so that it doesn't get lost before the next week when I get in there. We provide ongoing support. They can reach us 24/7 if they're in a jam with a patient. If we need to be at the hospital, we're at the hospital. And then regular monitoring, and that includes chart reviews, follow-up log reviews, calling patients, shadowing them in the hospital during my weekly visits, case reviews as a team, and then just observation of how they're handling it. Speaking with charge nurses and the ED director of nursing to see how the team's fitting together. All of those things are really important oversight with peer recovery coaches. They are crucial to this, and particularly in our hospital that we're working in, we find that the patients are much more likely to respond to these coaches than they are to some of the doctors or nurses. So their responses are key because a lot of times they're the first time that patient has opened up. We do have monthly team meetings with the coaches where we can share the data of how many screenings, referrals, patients that enter treatment. We review it. We look at any complex cases and see how we would handle it differently next time or maybe better, or how well we did handling it, always with the good feedback. We discuss any necessary changes to the policy and procedures and how it would benefit all of us. We do some chart reviews, and then we meet with the hospital team. So results to date, and these will be updated again very soon, between August and December, we screened 1,655 patients, and that's what the peer recovery coaches screened. We don't know what the nurses screened because there's no computer system to track it. Out of those screenings, 790 of them, 47.7%, were positive for drugs and or alcohol. And if you look on the audit C, those patients scoring from moderate risk 4 to 7 were 185, so at 23%. But what we really see in this hospital is those scoring 8 or higher on the audit C, 330, 41.8%. So we really had the patients that were at high risk, the score outweighing those with moderate risk. Of those 790 positive screens, we delivered 673 brief interventions. So 85% of the time with somebody screened positive, a coach was getting to them. That was pretty good for a pilot. We thought we wanted the number up just above 90, but it's still very good. And then we referred 174 patients to treatment. Those are patients that were on the readiness scale, agreed to go, accepted the referral. And of that number, we had 78 that actually were engaged and compliant in treatment at the end of December. So through all of that, everything that Marla and I both spoke about, we learned a lot of lessons. I think Les learned a lot of the same ones too. You have to start with committed leadership, and I know the bullet says hospital leadership, but in our case, it was the health center, the school, wherever it was. If the leadership wasn't on board, it wasn't going to be a success. The culture had to understand and be supportive of addiction as a chronic disease. We had to really change that thought process, eliminate that stigma within the system. The NIATEX principles of integrating into the workflow were important. When we looked and we thought we understood, sometimes those flow charts needed to be done 2 and 3 times before they actually were able to explain to us how the workflow went. And then we were able to look at that flow chart and see where SBIRT was best fit in. We found training alone wasn't going to institutionalize it. It was the going back, being visible, being available, answering phone calls, just making everybody visible. In the hospital in particular, the peer recovery coaches would go through each unit, introduce themselves to everybody. We gave some lanyard giveaways to the nurses so they would recognize that it had the SBIRT logo and the phone number they could call to get a coach, which was helpful. We learned we had to be flexible. As I said at the very beginning, you can make the best plans, but when you actually get it on the ground and running, you have to be willing to change them to meet the needs. The use of the paraprofessionals, the recovery coaches, has been amazing outcomes, but it requires a lot of additional time and oversight from your standard medical professionals, but well worth the time, well worth the investment. Again, the peer recovery coaches in SBIRT, part of their training was to learn when it was appropriate and practice sharing their own story in order to make our patients feel safe and able to be open and honest. And they are actually concerned that some of the nurses aren't able to get enough information because they don't know how to do this anymore. So they've really taken charge of that role. They really believe in themselves. Follow-up monitoring and training is key. When you see something that's not working, you have to get in there and change it. It's never going to work right the first time through. And then the development of relationships in the community with treatment providers. And key support services, crucial, because we need to reduce time when a patient's ready for treatment. We need to get them there as quickly as they can before they change their mind. And those relationships have really helped us to do that. We're working usually within 1 week of seeing the patient and being able to get them into treatment. And with that, I'm finished, and I'll give it back to Eric so we can take any questions.
Well, thank you, Colleen and Marla, for a very interesting discussion and presentation of what must have been a lot of hours of working on site, trying to figure out how to get this, what we know is an effective program, to make it actually work in real world settings. So I really appreciate your trying to distill this all into a presentation. There were a couple of questions which came in, and one kind of goes back to a slide that Colleen, you presented just a few slides back, where it wasn't quite clear to one of the listeners of what tools were used for your screening. So what was meant by a positive screen, and what you used as denominators when you were presenting the percentages of patients that screened positive.
Okay.
Because those percentages seemed, to me, they seemed very high, and so I'm just wondering if you already had sort of a pre-selected group that you were screening.
No, these were actually, every patient that came in through the emergency department was to be screened, and that was every time they came in. So if they were somebody that was screened a week ago, we rescreened them again. And this is in a very drug-ridden community, and we knew these numbers were going to be high if we could get honest answers from the patients. So what we did, the screening tool, the 3 alcohol questions on the audit C and 1 drug question, and if they answered, if the score was 4 or higher on an audit C, that was considered a positive screen. Or if they answered yes to any of the drug use other than marijuana, was considered positive.
Okay, so that's what your positive screen meant. That was, and then the scoring of 4 to 7 and 8 or higher is of those who scored positive on the audit C.
Of those who scored positive, that would have been the denominator, correct.
Okay, okay.
On the audit.
Right, and then for the drug screen, you used what, a single question, or what did you do?
Just the single question. It was on there's a slide of the actual screen. On slide 34, you can see the actual screen, if you want to look back.
Okay. Are the There's a number of questions about the peer coaches. Are the peer coaches volunteers, and what are the average hours per week that they work, and who takes care of all that scheduling?
So they're not volunteers. They're paid employees of the hospital, and they work 40 hours a week, and we split the shift. We decided that we needed the hospital covered from 6 o'clock in the morning till 2:30 in the morning. So we only have like a 4-hour window when it's not covered. And between the three of them, they work 4 10-hour days. And initially, Marla and I were doing the scheduling, and just this month we've turned it over to the charge nurse who writes the schedule for the nurses. And they've now been incorporated into that schedule.
How did you find or recruit these peer coaches?
I can address that.
Marla.
So we did put we used the hospital standard HR department and their recruitment procedures, and we initially developed the job description that was then approved by the hospital. And so the hospital put it, in the newspaper, on websites, but a big primary vehicle for us was really networking, and Baltimore had just completed its own development of a peer recovery core, and so we looked at a number of those individuals, put the word out through the recovery core, and we actually ended up recruiting one of the 3 from the recovery core. One of the 3 who's also an employee was in a different position of the hospital who applied, and then one heard about it through the network of treatment providers, and this woman had been working as a peer coach at one of our treatment providers. So I would say that it was really the non-formal recruitment. It was more the informal networking that allowed us to get these 3 folks.
And has your experience been that with these peer coaches and others in other settings that you've been recruiting and supervising, has there been much turnover?
We're still working with the same 3 that we hired at the hospital. So no to the hospital, but it's still, it's not quite a year old yet. Marla?
And we really haven't used them in our other SBIRT models, so this is really the first time that we've incorporated the peer model with SBIRT.
Okay. If you've had experience with several models of providers, and you chose to use peer recovery coaches for the hospital. As you think through your choice, was it a good choice?
Colleen, you want to respond?
I would say it was an excellent choice. The emergency room is a really busy place. The providers are stretched, as we all know, whenever we go to talk with them at health settings or at healthcare, community health centers or any center. They're very busy. They don't have time for one more thing. The community that we're working in is a tough crowd to get to open up, and they felt we were able to relate better to these coaches than they are to the providers. I think it was an excellent decision.
I mean, I think there's, pros and cons, and I think we're, still teasing out that because we're so new into the process in terms of, some of the biases and, the skill set that the coaches, bring or lack to the role, and what might be more helpful at times, to have, as Les has, more of a behavioral health specialist in the mix, but then the trade-off would be that, they're not a peer and they might not be able to get as far in terms of the relationship. So I think, we're still learning what, the pros and cons are, but I think there's, trade-offs, in any decision, and I think we're still trying to tease that out.
Mm-hmm. One of the there have been several questions that have focused on the amount of preparation time that you take and that seems to be required to get the programs to be operating. Can you talk just a little bit about what your sense is the amount of time, both sort of calendar time and hours, that it takes to move from sort of the first handshake with hospital leadership to the point at which you've got a program reasonably functioning?
I would say 6 months in terms of reasonable functioning. I think adding the peer recovery coach adds an additional dimension in terms of both planning time as well as supervisory oversight support investment in time. I think in the health centers, I think 6 months is reasonable with slow reduction in terms of the oversight. I think the upfront sort of investment in the planning, now that we've been doing it, can go a lot quicker as long as you can get people to meet. I mean, I think you can expedite that and get it figured out. I mean, within a month or 2 months. I think what we found to be a really critical investment in resources is really during that initial 3 to 6 months of once you start, really looking closely at that data to see, is this really happening? So once you do that training and you put the protocol in place, if you just assume that it's going to happen, we found it's a bad assumption because in our health centers, for example, initially at some of them, we only started with 25 to 30% screening happening where our goal was universal screening. And it really took feeding back, looking at that data, and then coming back and sharing that with the team, and then really working closely to observe what was happening to understand what was contributing to those lower screening rates or lower BIs. So I think, having that initial 3 months worth of really more close monitoring, data-driven monitoring and understanding of the operation in the long run is going to assure that it becomes a routine part of the practice.
So your experience is that after you do an absolutely fabulous training program of, say, all the nurses in the hospital, that doesn't make it happen.
Exactly. That's exactly what I'm saying. That I can guarantee you that it won't make it happen.
So say just a little bit more about the what you look at for monitoring and your process of going back and maybe gently reminding somebody who has been trained that, gee, they haven't screened anybody in the last year or the last week or whatever. What do you use for monitoring, and how do you provide that feedback?
So it depends on the setting. So in the health centers, we actually look at the number of screens that are being done and compare that to the number of patients that we're seeing in the clinic, and because our goal is to screen everybody who comes in the door. So we can look at the percentage of people screened versus the percentage of people who were seen. That gives us the percent screening. And then, where we have electronic health records in health centers, we're able to then look at based on the screens, how many screen positive to the alcohol score and those who screen positive to the drug questions, and then are the appropriate brief interventions done. And we have developed quick text for the brief interventions so that we're able to determine whether or not whether a BI was done appropriately, when there needed to be one, and was the appropriate BI done and a referral to treatment made. And so we collect all of that data where we can, and we feed it back to the hospital team, that core planning team, and we then go in and actually make an appointment and say, can we come watch what you're doing? And we actually observe how the screening and the process is taking place to then be able to understand what might be contributing to why it's not happening. And it could be something as simple as the form, is in the, in the wrong place in the EMR, or if we started on paper, the form's not in the room available, nobody's copying the form. We have a physician who just refuses to do BIs, and we needed to bring to the medical director's attention, or we need to have some one-to-one, additional booster training. In the hospital, because Bon Secours doesn't have an electronic health record, initially Colleen was collecting. We were collecting copies of all of the screens, those that screen, all the screens and the positive screens, so we're able to see the same level of detail that I just mentioned. But now that the nurses are moving to do the screening, we're now having to move to a more traditional QI method of doing a randomized chart review and looking at those charts to see whether or not we are getting the screening done and the referrals are taking place. But we can still see the number of referrals to coaches, and we have now the historical data for the last 4 to 5 months of practice. So if the numbers are going to go significantly down, then we know we have a problem.
It sounds very, very practical. And it seems like it's necessary in order to move from trust me, it's happening, to actually being able to provide active monitoring of the program.
Yeah, I mean, I think I can't underscore how important it has been to really have true adoption of the practice. And I'm really proud that in our health centers where we've been doing this now for 2 years, we really have true adoption of SBIRT. I mean, when we go in, because we're now starting to do pediatric SBIRT at one of the health systems where there's 9 sites, and we started with the adults. I mean, the center administrators, the doctors are telling us, well, it's in this form and this is how we do it. And I mean, it's really become part of what they do. And it's really wonderful to see. And I don't think that would have happened had we not spent that initial investment in really just really sitting on the folks to figure out how to get it to happen.
Well, I think what the two of you have presented is a very practical and real-world experience of integrating SBIRT into a wide range of programs. I think has been very helpful. Could you advance the slide to the last one that would have your contact information in it? There we go. I want to thank our 2 sets of presenters, Les Sperling at Central Kansas Foundation, Marla Oros and Colleen Hosler at the Mosaic Group. These were extraordinarily useful, practical presentations, and I am very pleased that you shared this afternoon with us. I want to thank everyone who has been listening, and if you have any additional questions, please either direct them to our presenters or to Misty Story or myself, and we'll make sure that the answers that you get the answers promptly. This presentation has been recorded and will be up on our Hospital SBIRT website, and it should be posted by tomorrow. So if anyone would like to refer friends and colleagues to the presentation, or you'd like to look over some of the slides that were presented, they will all be posted up on the website. The picture is here, and you can go directly to this webinar by clicking on the on-demand webinar, and that will take you directly to this set. Again, I appreciate the wonderful presentations that Les, Marla, and Colleen have given, and thank you for your attention.
The organizer has ended the session, and this call will be disconnected. Goodbye.